So rather than give you yet another heady message, you're about to hear two talks, mine and then one by Neal Shonnard, that should be some of the most uplifting stuff you've heard all day. Something actually really positive that the spine community in Washington State is engaged in doing, something that is going to be one of the answers that the governor's office can take to the bank and that we can all be proud of. It's an initiative that brings together everybody in the spine community, including folks who may not consider themselves part of the spine surgical community. People from the payer community, patient groups, the non-surgical community that helps take care of our patients before and after spine surgery. And this collaborative, which is referred to as Spine SCOAP, is going to be an increasingly important mechanism for you to have a really meaningful voice in what happens to your community rather than having it done to you, because that's the alternative. So 2 years ago, I believe, Jens, was it 2 years ago, Peter Fritzell was here from Sweden and he gave us this inspiring story about what they had done in the Swedish Spine Registry. At the time, I kind of warned you that we better do something like this in Washington State or otherwise they're going to do it to you. And the message was well heard because within the last 2 years and with a lot of energy in the last 6 months and through the support of lots of different stakeholders, the Washington State spine community has pulled it together, and I'm going to be talking a little bit about the rationale behind it, and then Neal's going to talk about the phenomenal progress to date. So let me just tell you, if you don't know about what SCOAP is, it stands for the Surgical Care and Outcomes Assessment Program. And this is really docs like you leading the charge to drive quality improvement, literally owning the process. The secret sauce in this is there's no lack of metrics, right? SCIP measures and Medicare measures, but the secret sauce in SCOAP is that you pick the measures. You tell us what makes a high-quality intervention, a high-quality operation, and then we convince your hospitals to define it, to track on it, and then we provide benchmarking back to you, really meaningful benchmarking that helps you drive quality improvement. The whole focus has been on the patient from day one, and with that comes reduction in bad outcomes, and that's what saves our taxpayer dollars. The data is real. It's not the billing data that will normally be used against you to profile you, but if Medicare does it. This is real chart-based information defined carefully by docs like you and abstracted by people who are trained for it. And it's intended to do benchmarking and change behavior by giving you information back, but then actually making you do something with the information through checklisting, through standardized order sets, through meetings like this where you get together and say, wow, isn't it interesting how early you intervene on your back pain versus we in Auburn or we in Bellingham or we in Walla Walla. It allows a community to learn from one another and get better. And it sounds Pollyanna, but I swear it's worked in general surgery, in bariatric surgery, in pediatric surgery, and now in spine surgery. And it's something to be really proud of. What it looks like is sets of reports that come back and show you how you look compared to your colleagues. This is for colon surgery, a report library that looks at thousands of cases, and then you can look at your hospital specifically and what your patients look like, both for risk and what they look like for a whole set of parameters on how you do the surgery. Everything from when you're operating on patients with malnutrition to how often you were able to keep the patient on blood thinners for the appropriate length of time. SCOAP spread like wildfire from starting with just 2 or 3 hospitals in Seattle to almost every hospital in the state. It spread because it's the right thing to do. You all know it's the right thing to do, and yet we haven't really ever been given the opportunity to do this sort of thing before. So the second the docs were on board, the hospitals were on board, and I have to say that surgeons are some of the most influential folks in a hospital, but as you know, the spine surgeons are the most influential person in a hospital, so I'm expecting that everybody in this room who is at a hospital where spine surgery is done will have their hospitals on board with the program. It's not being done by anybody. It's not being done by the insurance company. It's not being done by the government. This is run by the Foundation for Healthcare Quality. It's a nonprofit. It's supported by funds that come often from the hospital in the form of dues, but the Life Science Discovery Fund, which was part of the tobacco settlement, was helped at a critical time to help blow out the expansion of SCOAP from 16 hospitals to 46 hospitals in the course of a year. Those critical funds have helped make this a community standard, and it's one I'm hoping that we're going to accomplish in spine. And it made a difference. This is in colon surgery, looking at rates of leaking colons before the SCOAP program up through between 2000 and 2003, a pretty high rate of reoperative complications that dropped down just within 3 years by having docs focus on what they're doing in the operating room. This thing worked. It's dropped the rate, and it's dropped it in a funny way. And I'll just show you this slide. I know you don't do colon surgery anymore, but think back to when you did it in the operating room as interns. If you test for a leak in the operating room, you can know if it's leaking before you leave. Basic common sense. Every time you fix your kid's tire on a bicycle, that's what you do. And yet, some of us were trained to do it, and some of us were not trained to do it. Not surprisingly, when we started SCOAP, about 50% of surgeons did it. Last quarter, about 95% of surgeons did it, and that's what's been dropping the rate of complications. You have the same stories in spine to tell and the same lessons to teach each other. You just got to do it, and that's what's happening here in Washington State. We do this with data. We do it by creating a community. I'm always inspired when I come to a meeting like this to see surgeons figuring out what's working and what not working with one another, but we don't do enough community development. We don't communicate well enough with one another. This is an electronic community. You'll hear from SCOAP once a month about the data and where it's going and how it's working. You'll see it in your operating rooms, a checklist that the governor helped endorse and literally stand behind. It's now in every state, every hospital in the state, a checklist that can be modified for the things you know need to happen in a spine operation but aren't always happening. SCOAP works by picking targets, things like the leak testing I was talking about, a list of things that you will come up with in spine surgery. It tracks what we know, and it also helps figure out what we don't know. You heard before a lot of conversation about figuring out the evidence, patient-level evidence. I think that Gary Franklin and Elle and I would be happy in answer to your question about where's the patient in all this. If they knew which patient was going to get better with the fusion, I know that they would cover it because his whole mission is trying to get workers back to work. And yet we don't know because we don't have the evidence. And that's the kind of evidence generation that a system like this can do. It's not just about quality improvement. It can become the backbone for a learning healthcare system that figures out the subgroups, the heterogeneity of effect that a randomized trial could never do. And that's what we're doing. With a Life Science Discovery Fund grant that just came to SCOAP this month, we're creating the backbone of a learning healthcare system that's going to change the way we understand how spine surgery works, not in 100 patients randomized to one arm or another, but thousands of patients from every hospital in Washington State. The caveat is they have to be in the Spine SCOAP program to do it. So we're calling on every payer in the state, we're calling on the governor's office, calling on the BRE Collaborative to make this the community standard that we track on every patient who has surgery and that we track on a group of similar patients, to Dr. Kahana's point, that are not having surgery, because that's the way we'll all learn. We'll figure out where the value add is. We are in Washington State, a place that does some unusual things. We do it either because the weather's so lousy that we have to get to work, but for whatever reason we do it well, and it's collaboration. And this kind of collaboration, I think, is going to be a really leading force for what's going on in America. I'll just leave you with a couple of thoughts. One is that SCOAP works for a lot of different reasons, but it really helps to address the issue that we started the day off with. We are being crushed by the rising healthcare costs. These are the rising costs per year of SCOAP procedures in Washington State. The trick is, though, this is the cost at the non-SCOAP hospitals. The blue line, which is unfortunately not projecting so great, that's the cost at the SCOAP hospitals. And that gap, this $67 million, that's your tax dollars that are not being spent on complications that are going on at SCOAP hospitals. It makes a huge difference to do this work, and I encourage you to do it, because if you don't do it, it's going to be done to you, right? Let me just tell you that this fits into a much broader healthcare agenda. We have some shared goals. This is not just about reducing variability in safety, although that's important. It's not just about decreasing healthcare costs, and that's important. You know that the legislature is trying to address this issue and only has a couple of mechanisms. Usually it's pay or don't pay in the legislative sessions, or the regulatory approach is pay with conditions or don't pay with conditions. There is a way that you can control the dialogue about how your field gets regulated, how we get legislated to. And I'll just give you this Washington State bariatric surgical example. When we started SCOAP, bariatric surgery was the bad boy. There was horrible variability in rates of death across the state. As you drove across the state, tenfold mortality rates between hospitals. the Washington State Legislature was considering a bill that would publish everybody's mortality rates for bariatric surgery as the way to handle that kind of variability. Instead, they embraced the SCOAP agenda around bariatric surgery, linked payments to hospitals who were in the SCOAP program, and the bariatric problem literally went away within 2 years. We now have some of the lowest mortality rates in the nation. Think about that when I show you this slide. I've shown this before. This is Brooke Martin, who was in Washington State, using that statewide CHARS data and tracking variability of 90-day reoperation rates by Washington State hospitals. There are not a lot of legislative approaches other than don't pay. And that's one of the options if you don't take this stuff seriously. These are the rates of 4-year reoperation by hospitals. These are the rates of 4-year operation by surgeons. You're in here someplace. You don't know where you are, but you're in here someplace. Spine SCOAP helps you know where you are in there, helps understand the factors that are driving reoperation, helps understand when reoperation is really not an issue of quality at all. As many of you know, this is often as not an issue of the quality of the surgical care that was performed, but the patients that you're operating on. But unless you measure it, the legislature has no way of knowing it. That precautionary message I gave you a couple of years ago has been borne out. This is the legislative language from the Bill 1311, what we're calling the BRE Collaborative. Consistent with the authority granted in this bill, this authority shall convene a collaborative to address substantial variation in practice patterns or high utilization. That's you they're talking about there. They think that means poor quality and potential waste. That's you that they're talking about. And they shall identify up to 3 services a year that they're going to address. That's you that they're talking about. They're talking about spine surgery. The legislature declares that the payers, usually they can't get together in a room to talk about you, by the way. That's called collusion. But they're allowed to under this bill. The purchasers of the healthcare programs, private healthcare carriers, third-party purchasers, they can convene, they can come together, exempt from antitrust laws, for the purposes of trying to address that variability. And they can, for areas that lack evidence-based care, they can promote improved outcomes such as patient decision aids, provider feedback reports, centers of excellence. It's a powerful group, but the end result is that they want to use their legislative muscle to improve quality. Now, this spine community had organized itself enough so that when this bill was being put together, the notion of including in the bill the Washington State SCOAP program was something that they were receptive to. And I still think that they will be receptive to the idea of using a collaborative like this, a tracking platform like this, to be the vehicle to address variation in care, and also to be the vehicle that figures out when spine surgery is working, in whom it's working, and the corollary, in whom it's not really working. That notion of using Spine SCOAP and a collaborative built on Spine SCOAP, a wide collaborative that includes payers and purchasers and patients and all of the doctors who are involved in this care together, that's what you need to do to position yourselves for this BRE Collaborative. And it's not a negative, nasty thing. It's not like, what's the government going to do to us now? But it's actually a positive force that allows the voices of doctors to be heard, and it's a huge opportunity. This is what I think the spine agenda is. I've asked many of you in the state, mostly talking through the orthopedic surgical community, what's the shared goal? I've asked many payers, what's the shared goal? It's that the right people have access to higher quality, appropriate spine surgery. And that will save money, and that accomplishes that goal of reducing the burden of misadventures in the operating room. To get to that goal, you're going to need a couple of things. And because you've moved in this space in the last 2 years, you're almost there. Collaboration, targeting variability. You need to make an evidence-driven approach to this that focuses on outcomes that matter, that you can really measure. And that is Spine SCOAP. You are in the way towards, you've basically taken the key steps to building it. The idea was to build on the success of the program we did with colon surgery and other areas, and it's being done. And it basically gets you owning the issue, and that's such a great thing. We are now at the right place at the right time because of the work that was set up literally out of this meeting 2 years ago. The next talk is by Neal Shonnard. He's going to tell you the phenomenal progress that Spine SCOAP has made in the last 6 months. It is literally launched into a pilot mode that is now at 10 hospitals, and I believe within a year will be at 25 hospitals. This is an uplifting story, one of a community that really has taken the reins of an issue that they needed to take the reins of 2 years ago, and it's something you can all be proud of, and hopefully you enjoy the progress you've made. I encourage every one of you to think about Spine SCOAP for your hospital. If your hospital's not in it, this is a no-brainer. You can either join this now and be part of it, be part of the collaborative that's forming to regulate and understand how to reduce costs in your field, or you could be there leading the path and beating down the door of your administrators in your hospitals. And I obviously think the way to go is the latter. Thanks for the time. Look forward to questions.
So Neal Shonnard's going to talk about Spine SCOAP.
I want to thank Dave for the introduction. It really was a really good 30,000-foot flyover. I also want to thank him for this being his brainchild, because this is his brainchild. He's put a lot of work into it, and he's proven that this form of tracking, this way of following what you do, can give genuine benefit to your patients, and it's hugely helpful for your community, and it's the right thing to do. And it was, I also want to thank Jens and Mike Lee for giving the academic horsepower behind this effort, because they've spent a lot of time getting this launched and getting it off the ground. So we're starting off with Dave's finishing, and what Dave's finishing slide showed is that the key thing is to keep the patient at the center of what you are doing. The second thing is to measure what you are doing with measurements that you can track long term to prove that the benefit that you give in the recommendations and treatments that you provide, whether you be a surgeon or a non-surgeon, sustains. It's also critically important, and this is the great lesson of the surgical part of SCOAP, is that if you develop a collaborative of interested stakeholders, they will work in unison with you in a team approach to bring this forward and make it succeed. Dave's success in the general surgical field, with the variability in one surgical procedure having an enormous economic impact. As spine surgeons, you can think of multipliers of that benefit from the multiple variables that go into the way we treat our patients. And the benefit of studying that variability will be a multiplier beyond what Dave has done. And then lastly, being able to prove what it is that we do benefits our patients. And that's where Spine SCOAP comes in. The SCOAP data platform is the data platform which will allow you to track the good things that you do. When we look at how we got this together, what we did is combine both surgical and non-surgical experts, because ultimately you want to look at non-surgical care as a comparative cohort. So bringing those individuals together at the beginning allows you to develop shared definitions. And SCOAP is doctor-driven. The doctors define the problem. The doctors define the metrics, build the tool, and shepherd and audit the tool and the metrics to confirm that it works. And that means you got to get up early. You got to get up early every Monday for months and months and months, but your colleagues are motivated to do it, they enjoy doing it, and they like to see rapid and consistent progress, which is how the Spine SCOAP got launched from Jens's early encouragement to move this ball forward, following David's example of how to move the ball forward. And we established data points that we can follow long term. We were also careful to stay on a diet, because the experience of the Swedes, Peter was very helpful in telling us the things to watch out for. He was critical of what the Canadians did, which they got overburdened. They went asking too many questions. And so we've stayed on a data diet. We are not burdened by data burden. We're starting with the low-hanging fruit, proving that our retrieval mechanism effectively works, that we get the data into the server, that there are no bottlenecks in the flow of data into it. And we are doing that now since our launch in July, collecting 10% of our data. Watch that it flows effortlessly into the server, that our definitions are in fact correct, that our metrics are doable. We might think they're a great idea, but your team has to be able to do it. And if they can't do it, you have to change what you thought was a great idea. So that when you release it to collect 100% data from all of the hospitals that are enrolling in your program, the data flows effortlessly into the server. The people who are responsible for this are the hardworking folks across the state. We have a neurosurgeon from Group Health, VM. We have non-surgeon, president of NAS from Bellevue, Interventional Pain Management. Mike has been absolutely critical in providing the academic rigor to our work. Dean Martz, the president of the Washington State Medical Association, neurosurgeon from the Spokane area. John Singh, neurosurgeon here at Swedish. Farouk Farouki at Virginia Mason. And we are blessed with a team of experienced staff who understand comparative effectiveness research, who understand the process of gathering data, and very rapidly brought us forward to successful implementation of SCOAP. And we're deeply appreciative to the staff. They've been hugely helpful. The tool was modeled off of Peter Fritzel's original work, and it was platformed off of Dave's SCOAP platform. It includes all of the data that is relevant. This I will screen as the surgical tool. The non-surgical tool shares that it's divided by anatomical region. It has consensus diagnoses. For surgeons, it has the list of interventions that you routinely and customarily do. The lumbar region is similarly employs common definitions, and it employs common surgical procedures. In the non-surgical version, there are non-surgical procedures and interventions listed here. And then lastly, it is piloted in 10 hospitals in the state. So Spokane, and then up 5 corridor, so that the Swedish, UW, Peace Health, Multicare. We're gathering 10% of the data for 1,000 cases between now and December. We audit the tool and then go live with all hospitals, 100% of data, and then ask those hospitals who are presently not engaged in SCOAP but are interested in participating in SCOAP, please speak to us, because we have means for getting you into SCOAP and getting the data abstracted from your facility. So we will go live with 100% data collection in January. We will expand into other hospitals across the state and in other components, other modules of the spine SCOAP. The more complex modules will be brought online in 2012. The reason that we are able to accelerate the implementation of SCOAP is we have interested stakeholders who give undirected gifts to the foundation. There is no quid pro quo associated with this. There is no data sharing associated with this. There just is an understanding that with assistance, we can accelerate the development of tools which are used to get data out of doctors' offices, which you presently have difficulty doing, out of ambulatory surgery centers, which are presently not on EMRs, and out of fluoroscopy suites where much spine care is performed. And in order to do that, you have to develop those tools, you have to prototype those tools, and you have to pilot those tools to prove that they effectively do what you ask them to do. Also, you want to be able to get hospitals into your system by offering them ways to cover their abstraction costs during the piloting period. Because once you're past the piloting period, the abstraction costs are covered by the hospital. So this helps expand the reach of SCOAP within our state. And then lastly, this is the title slide that we originally started off on, that the fundamental issue is that the patient is first and foremost and central to what we were doing. Secondly, it's a doctor-driven process. We establish the definitions, we establish the metrics, and we're responsible for auditing the tool to make sure that we get done what we target to do. The Spine SCOAP platform is so uniquely gifted in its ability to do the things that we need to do not only as physicians, but we're asked to do by those who are in our regulator and those who are in our insurance collaborative, those who are our interested stakeholders want to know this valuable information. And we're ideally positioned, and this is an ideal tool to do that important work. So what I'd ask is, there are two things to understand about SCOAP. SCOAP number one is a data analysis instrument, but it's also a safe table platform. It's a place where you can come with your interests to try to give around the table with other interested stakeholders about what is important for our patients. I think that's basically it. You can contact us at the website or by email. Thank you.
If anyone has any quick questions for either David or Neal, yes, go ahead, Mike.
It's actually for Dave and Neal. I was wondering if you can comment on the medical legal implications and protections for this kind of data sharing. I think that's a concern of a lot of prospective members of SCOAP. And also, secondly, if you could comment on the onus this places on the surgeon. How much is this going to slow down their clinic? How much is it going to slow down their practice? And I think those are two concerns that people who don't know a lot about SCOAP might have.
What we have already trialed in my office is in getting the ODI, the VAS, and these various instruments done pre-operatively, integrated into the standard office practice. And that does not take long to do, and we have the techniques for doing it, or at least how my office has worked it out. And it's very reproducible, very successful, and it gives you that valuable preoperative data that you're going to use for comparison later on. So we are working the bugs out of that system so that when we go to our non-operative colleagues, we already have experience, because that's their first question. Are you asking me to do something that will interrupt my practice? No, we're going to ask you to do something that will enhance your practice, and it's seamless.